Welcome to Psychologist Talks. In today's episode, we're going to talk a little bit about bipolar disorder. First, talking about the criteria for diagnosis in of itself, and then differentiating between bipolar 1 versus bipolar 2. I'm not going to go through all the specific symptoms because those are things that folks can look up on their own. I don't need to waste time on that. We'll talk more about like the nuance behind the diagnosis and what really qualifies somebody for bipolarity versus other mood-related issues that could be confused for it, or personality conditions, etc., etc. So first and foremost, as the name implies, it suggests that there's a bipolarity, that there's a shift between two mood states. And this is largely accurate, minus the fact that bipolar 1, is kind of jumping ahead, bipolar 1 technically does not require major depressive episodes, so somebody can have these manic episodes independent of any other mood symptoms and still qualify for bipolar 1. So that the whole bipolar nature is somewhat misleading, but in my experience, those cases are typically a little bit more rare. That might be because I just don't operate, a lot of my work experience has been outside of private practice. I'm in a community mental health center for quite some time, and so I typically see more complex and layered cases. But for what it's worth, I can count on one hand the amount of cases I've seen that are strictly related to mania, and there's no other concerns. The other caveat too is often in those cases they're only seeing psychiatry because they're concerns outside of managing and trying to prevent these manic episodes are few and far between, and so they don't necessarily present for therapy-related needs. That's another possible caveat. I don't know the stats, if there's stats out there of people who only have mania independent of any concerns versus those who might have some overlapping concerns. Anyway, I digress. So there is the potential for depression. A lot of these cases will have depression. You can just go look up the criteria for depressive based concerns, and then the mania, hypomania is on the other side. What's really interesting in the diagnostic manual is the qualifications for mania and hypomania. They're almost identical between bipolar 1 and bipolar 2, which we'll get to. If you're thinking of like, how do I learn this better? Just note that if you understand the criteria of what constitutes hypomania, you largely understand the criteria for mania as well. But again, we'll get into the differences in a minute. One of the biggest things to note about bipolar disorder is and what trips people up the most, it's about symptom severity and temporal pairing of those symptoms. The way I describe it to folks is there needs to be pretty severe and pretty significant symptoms that all get onto a rocket ship together. And so this is the temporal pairing, right? So it's not just a bunch of discrete symptoms. 3 come up this time, these 2 happen all the time, these happen over here. It's a sudden shift from somebody's normal, quote-unquote, baseline, someone's typical functioning, and an influx of symptoms that's not the person's typical self or typical way of operating. They all crowd in together. They're all co-occurring together. And then this rocket ship takes off for 4 or 5 plus days. The threshold for bipolar 2 and hypomania is a little bit lower than mania. But they all have to be occurring together. So that temporal pairing is incredibly important. When you're looking through the symptoms of hypomania and mania, you have to kind of keep that in mind, that you're not just interviewing for the presence or absence of the symptoms, you're interviewing for when they can co-occur or not. So when you have screeners such as the mood disorder questionnaire, you can look through all of that, and they do try to say, are these happening together? But it behooves anybody who's a provider to really interview about those and try to track the narrative behind these symptoms. What are the ones that are omnipresent? They're always there. They represent in many ways an existing baseline independent of anything that would be considered bipolar. Obviously looking for changes. Does it amplify or get worse during certain periods versus those that come and go? But why do they come and go, and what do they come and go with? That is incredibly important to really establish what is the difference between shifts that happen due to other concerns versus shifts that are happening secondary to a bipolar process. Now, the severity of the symptoms also matters. So there's a lot of symptoms out there that overlap with other diagnoses. Racing thoughts are one of those symptoms that a ton of people will address if you just ask them point blank, do you ever experience racing thoughts? Well, guess who will say yes? Half of personality disorders, anxiety disorders, I mean, even depressive disorders are pretty notorious for like getting stuck in their own heads and potentially endorsing, racing thoughts, trauma, racing thoughts kind of in their head, rolling through things all the time. The description here is really, what I sometimes call is like you're trying to herd cats. This individual's trying to herd cats, so they're chasing rabbits that are running all over the place, trying to hunt rabbits, and they're going into their rabbit holes, and you chase one, and another one crops up, and it's just the rapidity of thought and the clouded nature of the thought is quite significant and quite stark. This is also what will cause focus issues and concentration issues. Not necessarily just a frank inability just in day-to-day life, but because their mind gets basically lit on fire, it is very hard for them to, really focus their efforts and attention on one singular thing. And so you'll also see that this cascades into other symptoms. This is also one of the reasons why they're calling people in the middle of the night, or there's an increase in goal-directed activities because they're chasing. Like, not only are their thoughts rolling, they're trying to chase these thoughts through their behaviors, and their behaviors become more disorganized, and they're often not finishing things because they're jumping between these rabbits that, sure, they can live just up here, but they will often lead to behaviors that can be quite disorganized or not really regulated well. So you notice, again, there's a more nuance here, because people can definitely have increases in goal-directed behavior, quote unquote, because they aren't depressed or their chronic pain got better or whatever it might be. They're like, look, I want to really capitalize on this time. So I have an increased felt energy unrelated to bipolar. I'm trying to get more done unrelated to bipolar. I have all these thoughts that usually with my depressive or anxious brain, it's more clouded, but there's like a concerted effort to capitalize upon them versus a cloudedness, and I'm overwhelmed by these increases in racing, quote unquote, thoughts. So you got to dig a little bit deeper. Insomnia is also a very common problem. So when we talk about like decreased need for sleep on the symptom list, that's also really important to interview around. It's like, what's the difference between a typical baseline of sleep versus a sudden decrease in the sleep, never mind the decreased need for sleep? So the follow-up inquiry is like, how are you feeling after these days of not sleeping? And they'll basically be like, I don't think my body missed it much. I was still going high octane, full speed ahead. And once again, that's different than people who are like, yeah, I have a decreased need for sleep because I'm, you talk to them and they're just a more anxious brain, and so they're up all night, and they can, or, you talk to younger kids and they're like, yeah, I ended up playing a video game because a new game dropped, and so I wanted to play that for several days, and I was able to make it like 1 or 2 days with very little sleep, but then it did eventually catch up with me because, when we're younger, we can go without quality sleep for longer than when we're older. When we're, interviewing older patients, usually, a day or two, and it's going to catch up with them as well. And it's not, again, necessarily decreased need. So, there's other ones on there, impulsive and risky behaviors. You have to be careful of dopamine seeking, people who are, quote unquote, addicted or trying to, avoid something in their life through these seemingly impulsive decisions, or thrill seeking, or things that, again, resemble a typical baseline. It doesn't have to do with a sudden influx of biologically driven bipolar related mania and hypomania. There's something else there. Now, this is often very hard to get all these details in a single sitting. And so, do note it takes time to interview and get to know these people's symptoms. That's never a good term. Folks diagnosed with bipolar or potentially diagnosed, to really understand and contextualize them. So you might think it's bipolar initially, but upon further interview, go, well, wait a second, maybe not, and vice versa. You might think not. But as you get to know them, you're like, ooh, never mind. Maybe there is something else going on here. Now, I will note another challenge with accurately diagnosing bipolar disorder is accuracy of report, or a different more clinical term. Think of it from like an insight point of view. A lot of the details of how people describe symptoms and their awareness of temporal pairing requires a good deal of insight. And there are some people who are very motivated to keep their diagnosis, and because they identify with it and they've read all about it, and so they'll spit things out to you that sound very bipolar-like, devils in the details. But on the other end, there are also people who are like, I don't think I have this, and they will, their report will mold around these ideologies. Do I have it or do I not? And I have myself caught people, not like, this is not like a malicious thing, but I've had people try to convince me there's nothing there, and then I pull hospitalization records and it's like, holy moly, this is mania. Or people who will kind of downplay their symptoms, or they don't really see it, and then you interview family and the family's like, whoa, no, it's way different than that, it's way worse than that. So you do have to be careful, but you also have to allow yourself to be somewhat imperfect. This is very challenging in some cases to catch these diagnoses well, especially bipolar II, because bipolar II has a subtler nature to it. So just bear that in mind, that we are heavily reliant upon the client themselves reporting accurately about their functioning. And when we try to protect boundaries and not be like, conferring too much with family, that can serve as a disservice, because we don't get to follow them around every day. We don't get to observe them the same way that family members do, which heads us into part 2, which is differentiating between the two, and how this idea of like, what do other people see is a major factor in it. So let me double check though. Is anything that I'd be missing on the diagnostic side? I think that's it. Again, emphasis on the nuance of the symptoms, the severity therein, which we'll get to further here in a minute, and then temporal pairing. Really, truly the temporal pairing and the rocket ship. I think it's a powerful imagery. Is we're not just like floating across an ocean here. This rocket ship takes off and orbits the Earth for days on end before it crash lands. It is a stark experience when we talk about mania and hypomania. Now, how stark, again, we're about to get to. So, when we talk about starkness or severity, that is one of the major differentiating factors between mania versus hypomania. I think the language they use in the diagnostic manual for mania is an unequivocal change in functioning. I'm sorry, I got that reversed. This is the problem of me not looking at notes. A marked impairment in functioning. And the way I describe this to folks that I train is, think of it as, is highly unethical. You would not be able to run this study, but say if you lined up 10 people on the street, random people not versed in mental health care or diagnoses, and you have somebody observe someone who's in an active manic episode. 9 out of those 10 people are going to say something's going on. This person probably needs some sort of help. It's that disorganizing. It is, as a provider, if you've never seen someone in active throes of mania, you are often like, strap yourself into the chair. It's going to blow you back, because it is high intensity, very high energy. It is palpable in the room. There's a strong feeling in the room, and hence this marked impairment. Hypomania is trickier because they say it's not marked, but there is an unequivocal change. What they mean by that is basically if you observe them enough over time, people who might have bipolar II or experiencing hypomania, if you observe them enough, you'll start to notice something's up, right? There's this shift. There's some sort of inconsistency in their functioning. But notice the language there. It's not like right away. It's going to take you time. And it even takes families who are around these individuals for a long time to go like, something's up, right? Like, it's not marked, so maybe they're having good days, and I'm happy for them that they're not feeling depressed, because depression is a requirement for bipolar II. So not depressed, they're doing better. They're not like blowing up their lives completely, so I want to be happy for them. But over the months or years, they're like, hold on a second, something is not adding up. Like, what is this back and forth shift about? Now, if we use that same idea of lining up random strangers on the street, unethically observing this individual in a hypomanic episode, you could have anywhere from like 5 to 6 to 7 to 8, heck, even possibly 9 out of those 10 people going, good on that person, I'm glad they're having a good day, or ooh, they seem a little bit irritable, I wonder if something bad happened to this day. But they're not going to flag the person that they don't know and say like, ooh, for sure this person's going to need some help. You still might get that 1 or 2 or 3 kind of floating around going, I don't know, that seems a little bit off. But it's so subtle that for people who are none the wiser to this individual, they wouldn't be able to discern between a normal baseline versus hypomania. And this is where it takes time often to accurately diagnose hypomania. This is especially true because people with bipolar 2, people diagnosed with bipolar 2 often come in for treatment focused first on depression-related issues. And so their central notion of what is most troubling to them is typically on the depressive side, not on the hypomanic side. And so the hypomania takes longer to ascertain while you're noticing the depression. This leads to another major difference between bipolar 1 and bipolar 2 is usually bipolar 1 with mania, when they're in mania, they're going to need hospitalization at some point. I mean, they can go okay without it and not be a risk to self or be labeled necessarily possibly as gravely disabled, but often it gets so bad that it's like, holy cow, we need some sort of crisis intervention, some sort of stabilization. And this also co-occurs with another thing that's unique to it is if psychosis ever occurs during a manic episode, it is mania. Let me say that differently. If psychosis is occurring during this shift in mood and behavior, then it's going to qualify for mania. And this is also another reason why they'll often hospitalize, is when it co-occurs with psychosis, the destructive forces it can have on the individual's life, the delusions and paranoia and those sorts of things can be quite substantial, because now their impulsive behaviors aren't just driven by this sort of rocket booster. It's also driven by reality testing issues. Is where you can have people sinking thousands and thousands of dollars and dumping their life savings into things off of some delusion, or people are following them or whatever it might be. Whereas with bipolar 2, it often doesn't necessitate hospitalization. It very rarely does, and it doesn't co-occur with psychosis. The minute it's psychosis, it's got to be mania. So hypomania, you're not getting any psychosis. Now, when do people with bipolar 2, diagnosed with bipolar 2, typically go in if they are ever hospitalized? It's when they're depressed, suicidal ideation. That's typically the reason that'll draw them into a hospitalization, if at all. And again, depression is unique to bipolar 2, whereas bipolar 1 with mania can occur with, and often does with depression, but it's not required, technically speaking. And so those are the major differences. Not many, right? Like, again, you look up the symptom list for mania, hypomania, remarkably similar. It's about that intensity, severity, and those kind of a couple qualifying factors that differentiate between the two. And so providers will often float between the two of these without really differentiating effectively between them. Bipolar 1's very serious. I mean, you talk about the necessity, the felt urgency for families and individuals and the providers themselves to prevent the manic episodes. It is palpable because of how severe those episodes are. And they can have hypomanic episodes behind that mania nonetheless, but those sudden influxes of mania that are unique to bipolar 1 are highly destructive. And there's a lot of urgency to put caps on that. Bipolar 2 is more challenging because they often, individuals with bipolar 2 will often enjoy their hypomania and feel a sense of loss because it's not so dysregulating and so destructive. That when they do the pros and cons, there's so many pros next to whatever cons exist. They often struggle wanting to stay on medication because it's like, well, I'm not blowing up my entire world. And especially when you get into like side effects with medications, they can have a numbing effect. Some people complain of those. And so there's this trial and error and needing to talk to their providers, their psychiatrists, and their prescribers about like, okay, it's helping me. I'm not having those highs, but I also feel numbed out. Now, I'm not trying to discourage or say to anybody that's assuredly going to happen to you. I'm just trying to be real that there is a struggle that sometimes happens for folks with bipolar 2 of wanting to come in for treatment for their their highs, because those highs are desired, or there's a familiar relationship with it of sure some cons, but also some productivity and some things that they can look back positively on that happened potentially during these hypomanic episodes. So that's the I was gonna say quick and dirty, but that was 20 minutes. That's probably about as quick as I can go for bipolar, just kind of canvassing real quick the diagnostic criteria and the nuance required around the interview of that, and then a quick differentiation between what constitutes a bipolar 1 condition versus a bipolar 2. Will we add further types in the future? I don't know. I'm not in these these panels for the diagnostic manual. I know they've been playing around a lot with as we learn more about bipolar, but so far they've kept it pretty consistent over these last few decades. They haven't really changed too much when it comes to the diagnostic criteria. So I hope it's helpful, whether you're a consumer or somebody who might be concerned that they have some sort of bipolar condition, or if you're a provider who is curious about how to accurately diagnose. I know I didn't go into differentiation and saying how do you differentiate between X, Y, Z conditions, but again, trying to keep this short and focus solely on what it is. So as always, thank you for listening and watching, and stay curious.